Hello, and welcome to another episode of AUA University Podcast, where we explore important and evolving topics that shape urologic practice through expert discussion and evidence-based insight. I'm your host, Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today's episode focuses on one of the most rapidly evolving and clinically consequential areas in prostate cancer care, salvage therapy after radical prostatectomy. We're going to unpack when to consider salvage therapy, how new imaging and trial data have shifted our practice, and decision-making pearls that can help urologists optimize outcomes while minimizing overtreatment. It's an important, nuanced topic, and we're lucky to have one of the leading voices in the field here with us. I'm delighted to be joined today by Dr. Yaw Nyame, Associate Professor of Urology at the University of Washington School of Medicine. Dr. Nyame has expertise in clinical trials, cancer disparities research, and implementation science, and brings perspective not just on what evidence may show, but how we can actually deliver high-quality salvage therapy in real-world practice. Dr. Nyame, welcome to the podcast.
Well, thank you very much for having me. It's a pleasure to be here today.
So let's start with one of the most important paradigm shifts. For years, adjuvant radiation therapy was considered the default for patients with adverse pathology. But now several landmark trials, including Radicals, RAVES, and GetDug AFU 17 have reframed that conversation. Could you walk us through how these trials collectively have changed our thinking about adjuvant versus early salvage radiotherapy?
I think this is one of those topics that really has evolved. When you think about the advent of adjuvant radiation following surgery, it's based off of a trial that was done in SWOG by Ian Thompson, really one of the major figures in contemporary prostate cancer management, and a trial that he started as a fellow. So it's really incredible, that work, and it really did help shape how we provided care to patients. What was interesting and challenging, I think, about the SWOG trial is that two subsequent trials conducted didn't show the same overall survival benefit. They've all shown metastasis-free or recurrence-free survival benefit, but not overall survival benefit. And Dr. Thompson's trial was the only one to show that benefit. There is no doubt, and this came into our guidelines for the AUA Astro guidelines. There's no doubt that when we combine multimodal therapy, we have more side effects, right? So when we operate on patients and then we give them radiation, they're going to have more toxicities from a urinary standpoint, sexual standpoint, and even bowel function. And so I think part of what we've really been seeing evolve in the field is trying to better understand who we should give radiation to, so that we don't reflexively have the reaction of giving every patient with a small positive margin or with T3 extra prostatic disease or some other high risk feature adjuvant therapy. And if I had to distill these three trials, you have Radicals, you have RAVES, and you have the GetDug AFU trial. What they summatively tell us is that if we wait for the PSA to go up and we treat early enough with standard of care pelvic radiation, that we can still appropriately salvage patients who recur, and we avoid over-treating roughly 50% of patients that have surgery that may have features that look high risk to us. So this is really, at least from my vantage point, a very big paradigm shift that had slowly been occurring. Practice patterns had evolved to really where most practitioners were favoring early salvage, but in the last 2 years we've really had high quality phase 3 clinical trial data to back up that behavior.
Yeah, and it's important to bring up the fact that application of newer data or emerging data like this really relates to us as clinicians trying to provide the best possible cancer control outcomes for our patients, but trying to impact quality of life in the least amount of way. And, I think it's a balance. And obviously, there certainly is a real world shift that has occurred as it relates to the data that was uncovered in these trials. from a practical standpoint, for the urologists who are listening, how would the data in this domain have changed your postoperative counseling for patients? What are kind of the pitfalls from this when we as clinicians are transitioning from, as you pointed out, that historical adjuvant mindset, right, to more of this salvage strategy? So any practical considerations for those who are listening when we talk to patients about?
I mean, it's really I've flipped the way that I share pathology with patients, right? And part of what I really hone in on is, these particular findings that you have may be high risk for recurrence and progression. Um, but I think I've really gotten away from using language like this high risk feature needs immediate treatment. And I think for a lot of patients who are looking at, best case scenario, a few months to recover, function and get back to maybe having good urinary control and starting to see some early signs of sexual function. And that's an optimistic target, letting them know that they don't have to immediately go into another treatment should they need it, is really helpful. So typically I'm driving home in the car when I'm sharing pathology. It seems to be, I have a long enough drive to get at least a couple of phone calls in, and I always ask patients for their permission. They don't seem to mind. And I always say, we're gonna go through a few things, right? One is going to be, what high risk features do you have at surgery? Is it a high grade tumor? Is it involving, extra prostatic involvement? Is it involving the seminal vesicles or the lymph nodes? And, all those things I take together, and what I try to really do is prime the patient for the possibility of recurrence, right? So if we think 1 in 5 men who have surgery, if we're taking everybody collectively together, will experience a recurrence. I always use that as a frame. So if you have some of these high risk features, that typically doubles your risk. Positive margins double your risk. And oftentimes I'll share that as, okay, now that we have this information, should that PSA go up in a year or so, let's not be surprised. We have great therapies that we can use in the second line that can still offer the ultimate goal for our patients, which is to be cured or to have long-term survival from a cancer standpoint. And that's really how I've thought about framing this information. I always say our first PSA, which I tend to get a little bit earlier, I essentially get a 6-week PSA on everyone as a preference. That's kind of a quality check. That PSA should be undetectable, and if it's not, that clues us into something else going on. And oftentimes we have major clues that someone might have that, right? Multiple nodes that are positive, or something that, surprising in the path that might lead to that. But I find a lot of patients are reassured by early undetectable PSAs, and then, because of the way we counsel, the PSAs start to go up. They're ready. Oftentimes I don't have to prepare them for salvage right away either, right? It's a 0.05. Okay, well, it's a low level detectable. Let's see what happens in 3 months. And, that as they recover and as we continue to evolve that patient-doctor relationship, I can start to prepare them mentally for a second line of therapy.
Great. No, those are very important points. And I think this is a good transition. You start talking about PSA, and we're fortunate in the field of prostate cancer to have such a sensitive and a great biomarker to follow patients with. One challenge in practice is we moved from that concept of adjuvant therapy to early salvage therapy, right? Is trying to define what early salvage actually means. Many clinicians will still struggle with the timing. How low is a low PSA when we're talking about initiating radiation, and want to get your thoughts on that.
Yeah, there's been wide practice patterns historically on what people did with PSA levels, and I think reflecting at the time limitations and tools. When you started that question, the first thing I thought was, oh man, how many people really hate that ultra sensitive PSA, right? For a long time you had a PSA less than 0.1, it was easy, and now you got to have a long conversation about that 0.05. And I personally use that as an opportunity to start having that discussion. Oftentimes that first detectable low PSA it's cluing you into something going on. They usually will have pathology that will also kind of correlate with what you're seeing. And so I use that as a preparatory kind of piece of data. However, to answer your question specifically about what is early, I think there's a really wonderful study. There was a multi-institutional study published in JCO in 2015 by a radiation oncologist named Rahul Tendulkar. And if you want to know why I remember all of this, Rahul was at Cleveland Clinic. And so I had the pleasure of kind of seeing and hearing about this early data as a resident. So it's one of those things that's kind of seared into the brain. But if you look at that JCO paper, they looked at various PSA cutoffs following prostatectomy and looked at response to radiation therapy using metastasis-free survival as a surrogate endpoint. And what you saw very beautifully in that study was that the lower the PSA, the better the response to treatment. And really, there seemed to be a divergence in response around a PSA cut point of 0.5. And certainly those who got above PSAs above 1 did the worst. And so for me, it's always been a really simple kind of equation. If we define biochemical recurrence as a PSA greater than 0.2, I'm trying to land in that sweet spot between 0.2 and 0.5 to initiate therapy. And certainly I'm trying to avoid getting above a PSA of 1 at any point in their postoperative surveillance before I initiate a treatment.
Oh, great. And, it's a nice high-level overview as well of the results of that Tendulkar study. To boil it down from a practical standpoint to patients, when they feel, quote, perfectly fine after surgery, right? They may be following you. You've got this low-level ultra-sensitive PSA. It really can be a challenge for us, right, to recommend therapy at even those lower levels, say between 0.05 to 0.1. How do you communicate the rationale for early intervention to your patients without creating unnecessary anxiety?
Yeah, and I will tell you that it's not my practice pattern to treat at lower PSAs than 0.2 for that reason. I think anyone who's done prostatectomy long enough has a handful of patients that get to a PSA of 0.07, 0.1, and it just stays there, right? And so I think it's really prudent that we don't overtreat. However, the guidelines, we deliberated this, and there's no doubt that most folks who are starting to have some detectable low level of PSA, that they typically will cross that 0.2 threshold. And I do think that there are some practitioners and institutions that have a practice of treating earlier. And you may ask, well, what's the benefit of treating earlier? And that is really the potential and the higher likelihood of avoiding concurrent ADT with radiation therapy. There have been several trials that have looked at the benefit of the addition of ADT to radiation therapy. And a secondary review of one of those studies showed that when PSAs got above 0.7, that it seemed like omitting ADT was associated with worse outcomes in the patients in that clinical trial. This is a study done by Dan Spratt. And so this actually made it into the guideline recommendation that if someone has a PSA above 0.7, you really should be adding concurrent ADT to radiation therapy. So one could argue that if you have a patient who's continent, functionally doing quite well, is having to have those consecutive rises in PSA, ultra-sensitive PSA, and still below that threshold of 0.2, maybe they had a couple of high-risk features at surgery, that would be very reasonable to institute that earlier radiation treatment and avoid adding concurrent ADT.
Yeah, I know that's a great transition as well when we're talking about multimodal treatment for these patients, because the addition of ADT, obviously, to salvage radiotherapy certainly has been increasingly data-driven, but it's definitely nuanced, as you point out, not only depending on perhaps PSA levels and recurrence, but also with regard to the duration, of ADT treatment. Now, when clinicians are going through that ADT decision-making process, I don't know if you can help us understand perhaps some mistakes that might be commonly made during salvage therapy, and how one might avoid both undertreatment and perhaps even overtreatment.
Yeah, this was really challenging, and we have a multidisciplinary prostate cancer clinic, and oftentimes when I have an opportunity to, this is what I'm poking the bear a little bit, like why are we doing it this time but not in others, and when should we do it? We've had a lot of data come out. Sport trials showed benefit to the addition of ADT. I think Radicals had some data around ADT use. A little bit hard for me to wrap my mind around. It seemed like 2 years of ADT was beneficial in avoiding metastasis-free survival. However, in some of the preliminary data, it doesn't seem like there's an overall survival benefit. I know some of our med-oncs have, view that data kind of as maybe we shouldn't be doing concurrent ADT. But I always think back to one of the first things I heard one of my mentors, Dan Lynn, say, that there are very few studies that show that the combination of radiation and ADT isn't better than, radiation alone. And if you look at the basic science, there's a synergy there. And so it's hard for me to avoid that ADT. And I think the guideline panel took the same approach that I do in my practice based off of the evidence. There's no doubt that there's a handful of high-risk patients that probably would benefit the most from that combination. And those high-risk features are something that you really want to be clued into. And for me, when I think of high-risk features, I'm thinking really specifically about pathology, right? So if my residents listen to this podcast, they won't be shocked when I say seminal vesicle invasion. That is a really high-risk feature, right, at prostatectomy. It goes without saying that lymph node involvement is a high-risk feature. And sometimes we'll talk about margins. Well, yeah, margins haven't been associated with an increased risk of death. SPCG4 tells us that. So we have a large trial pre-PSA era that has looked at long-term survival, 20 years, that showed that margins weren't a predictor of death, but they sure are a predictor of recurrence. So then that gets into the nitty-gritty. Not all margins are the same. What kind of margin did you have? Was it a high Gleason pattern at that margin? Was it a very large margin? And so I'm really wanting to take all of these different data points into account. One of the highest risk features that you can have when you look at the Egner-Stevenson nomogram from Memorial Sloan Kettering, which has always been kind of my North Star on what is bad after surgery, is your primary pattern, Gleason pattern. So you got a primary pattern 5 tumor. I mean, that's telling you a lot about the biology and what's going to occur. So in a patient like that, if they have that PSA recurrence, I'm not thinking, oh, well, it's your PSA is 0.2, maybe monotherapy. I'm really trying to maximize the efficacy of that second line salvage therapy. And I'm definitely going to do concurrent ADT. And we have some evidence to suggest that we should probably be carrying that ADT into the long term, looking at 18 to 24 months. And again, this is not, I haven't had time to really do a digest of radicals and, this 24 versus 6 versus 0 months. I think the data hasn't matured either, but, we have to keep in mind that radicals was looking at a higher risk population. So perhaps the reason that the longer term ADT group did better and had lower rates of metastasis over during their follow-up is because they had a longer duration of ADT for that high-risk disease.
And I think you nicely covered all of the details regarding pathologic factors that would constitute high-risk features for our patients. And, certainly we recognize clinical factors, including, perhaps PSA persistence, time to biochemical recurrence, and even PSA doubling time. And it's interesting how all of these factors can potentially interact to influence, radiation dose, fields, and ADT duration, as you mentioned.
Yeah.
Given all of this and how even for us as clinicians, it can be complex. How do you? I don't know if you have any, advice, because we want to find out how you might translate these factors into a simple kind of easy discussion, right, algorithm for patients, something that they can understand while making, a potentially emotionally loaded decision?
Yeah. I mean, I think there are some really strong guiding principles we should live by in this space, right? I think first and foremost, the most patient-centered thing we can do is to provide salvage therapy, and especially in those who are nadir to undetectable. And so we should let the PSA dictate what we do next, and it should be timely, right? The second thing that we haven't covered, and this could be another 30-minute, conversation, is we have really this new generation of imaging, this PSMA PET, and that really should be guiding our decisions because for as many times as we've found, we have a negative scan, which is like 50%, or we find something in the pelvis. There are those cases where, the thing that lights up post-operatively is a rib lesion, and the ability, again, to treat the right thing is really important. And I think imaging gives us that, affords us that luxury. Next thing is we've been talking about salvage, and we've been having this conversation, and I've been covering hormone therapy, systemic therapy. I've been talking a lot about radiation therapy, and so clearly this is a multi disciplinary kind of discussion, right? And so these have to be managed in a multidisciplinary way. And I think for anyone in any practice setting, hopefully you have those partners in radiation therapy and medical therapy that you can lean on to say, okay, how concerned do I need to be about X, and how should we plan this treatment? And then last but not least, I think the jury is out, and there's no doubt that whole pelvis radiation is superior to, node only or prostate bed only therapy. That the addition of nodes to the prostate bed leads to better radiation in the salvage setting. And again, we have a clinical trial data, phase 3 trial that tells us that. So those are kind of the things that I think about. And then, in 2025, head into 2026, the space has evolved, right? And we talked about imaging, right? What do you do now if you have one retroperitoneal node that lights up? And this is what our tumor boards are consumed with. It's like, okay, what do we do in this setting? Do we provide metastasis directed therapy? I mean, this is a space where I think you're going to see a lot of investigators pursue studies, and because we need some new answers to understand what to do. But that in that setting, I think we're in a data free zone.
Yeah, no, and obviously there's been a lot of practice change with introduction of PSMA PET. A lot of folks in the audience, I hate to say it, myself included, remember the days of CT scan and bone scan, right, for metastatic workup. And when you talk about post prostatectomy PET, I want to get your thoughts. Again, this is an ongoing challenge as we begin to understand the utility of this type of next generation imaging, which really is emerged as the new standard of care. What to do, for example, when PSMA PET is negative, right, at very low PSA levels. I mean,
we, like I said, up to half the scans are negative when the PSA is as low as it is when we initiate it, right? And so the detection rate goes up as the PSA levels goes up. And then paradoxically, I said, but don't let the PSA get to 1, or the PET scan would actually have a higher detection rate, because we want to radiate when the PSA is as low as possible. What I tell patients is a negative PET scan, we revert back to what we did with conventional imaging, right? So if your PET scan's negative, we're going to do the thing that we've proven works historically, and that's pelvic radiation combined with potentially ADT for 6 months to 24 months, depending on kind of your risk group. And I tell them, look, if there's something in the pelvis that lights up, that was going to be part of our radiation field. Great. Our radiation oncologist can even boost some of those areas sometimes, but we're going to give you what we know works, and we're going to have a justification for it, right? And there's a perirectal lymph node, and that's where recurrence, or it's at the anastomosis. To me, the real quagmire is what you would do with these oligometastatic recurrences, I've yet to find a great answer to that. Obviously, we've had a few small trials, phase 2 trials, that have provided us some insight. We probably delay the time to ADT. when we do metastasis-directed therapy. And so the answer I don't have is how much value does a patient derive from that? And I actually, I'm going to show my cards here. I'm like patient. All of my research I do is in partnership with patients, and so I drink the Kool-Aid fully. But I probably would say we need to ask patients that rather than trying to come up with some surrogate or an endpoint that we want to measure clinically to capture that. We probably should be asking patients directly, like how much value did you gain from having this, spot radiated and maybe getting an extra year or two without ADT. So, because if the patients don't find that to be valuable, doesn't improve their quality of life, doesn't extend life, which I think we're going to get a little bit more data, then maybe we shouldn't be doing it. Maybe we should be waiting until patients are symptomatic or something like that to start them on systemic therapies that are actually quite effective.
Those are great points. And we're coming up to the end of time. This has been a fantastic discussion, clear, evidence-based, and incredibly practical. We know that salvage therapy, is one of those areas where timing, risk stratification, and as you pointed out in the last comments, communication really all play a huge role, and your insights really help bring that together. So thank you for being with us on this podcast today.
Pleasure's all mine, and look forward to maybe another opportunity to come back and talk updates on this topic sometime.
Thank you. And to our listeners, thanks for joining us. For more educational content and resources, visit auanet.org/university. I'm Dr. Mark Gonzalgo. Thank you for joining us on AUA University Podcast. Stay informed, stay engaged, and continue advancing the science and practice of urology.